Good morning, everyone. It's my pleasure to welcome you all for the day 2 of our conference. I hope you enjoyed the first day of our conference and the dinner afterwards. So we'll get started. I would like to invite on stage our first panel of speakers, Dr. Abba Malloum and Dr. Luca Incrocci, who will be talking about hypofractionation radiation therapy use in Africa. Thank you.
Good morning, ladies and gentlemen. Thank you for the opportunity of giving us to share our ongoing clinical trial. My name is Abba Malloum. I'm a clinical radiation oncologist based in Durban, South Africa. I have no conflicts of interest. Right. This is a study about a prostate cancer in sub-Saharan Africa. Just as a background, prostate cancer is the leading cause of cancer and cancer-related death in men in sub-Saharan Africa. In the year 2022, about 86,364 new cases were reported, more than half of them associated with mortality in sub-Saharan Africa. The higher mortality incidence to ratio in sub-Saharan Africa is about 0.6. compared to the Western, which is 0.2. Prostate cancer incidence and mortalities in sub-Saharan Africa predicted to increase by 131% and 138%, respectively, by 2040. And men of African descent are disproportionately affected by prostate cancer compared to the Caucasian group. They have an early presentation, more aggressive disease, and higher mortality rate. Now, a study that was done in the Western world, which was reported by Lancet Oncology, about the hypofractionation, comparing a 3-arm of study. And in that study, they have a report of 7 years about the biochemical-free survival and overall survival. In the slide A, we can see that hypofractionation, it has reasonably compared with the conventional. And if you see the overall survival, at the time of report, it has the same overall survival with statistically significant. Hypofractionation is to employ a higher radiation dose per fraction in fewer fraction versus the conventional. Now, prostate cancer radiotherapy, example, previously we used a conventional of 78 gray in 39 fraction versus the moderate hypofractionation, where about 60 to 62 gray in 20 fraction is employed or used at the dose of a 3 or 3.1 gray per fraction. So a study in the Euro-American shows that or demonstrated hypofractionation in prostate cancer is not inferior to the conventional fractionation in terms of toxicity as well as the outcome. Now, in the year 2018, the ASCO, and AUA recommended the use of hypofractionation to treat prostate cancer. The clinical evidence of hypofractionation toxicity and treatment outcome is only from the Western world. We don't have any data from Africa that motivated the group called Hypo Africa come with an initiative by our prime PI, Prof. Luca Incrocci. We come for a feasibility studies where a multi-center prospective non-randomized phase 2 study, non-inferiority trial to examine hypofractionation for treatment of African men with the localized prostate cancer. The sample size of this study was 182 It is the dose of 60 gray in 20 fraction for low and middle income, low and intermediate risks, whereas 62 gray in 20 fraction for high risks. The primary endpoint of this study is to see the grade 2 and above acute and late toxicity of genitourinary and gastrointestinal, whereas the secondary endpoint of the study is to see any grading toxicity of the gastrointestinal and genitourinary. The other secondary endpoint are serum PSA level-free survival, relapse-free survival, the number of patients lost to follow-up, as well as the cost-effectiveness of using hypofractionation. Inclusive criteria, as usual, so most of the patients, all the patients with a localized prostate cancer confirmed histology, low and intermediate risks. Any patient with a serum PSA is not a cutoff for this trial, but definitely all the patients have negative node, no distant metastasis based on CT, MRI, or PET PSMA scan. Of course, they have given an informed consent, followed by willing to participate for the treatment follow-up up to the 5 years. The exclusive criteria for this study, those with the radiological evidence of pelvic nodes, present of distant metastasis, candidate for elective lymph node irradiation, inflammatory bowel disease, previous radiotherapy, and unwillingness to participate in the post-treatment follow-up. Now, our prime PI, as I earlier mentioned, is Prof. Luca in Ukraine from New Amsterdam Erasmus Center, and the study coordinator, Prof. Wilfried Ngwam from Johns Hopkins. The lead PI of the Africa is Professor Emeritus Twalid Ngoma from the East Africa. We have Joseph from West Africa, Nigeria, myself, South Africa, and Solomon from Uganda. Now, this is our preliminary results. On the preliminary results, the median age of our patients was about 70 years of median age, which is comparable to the global world. If we see most of our patients is high-risk group, about 103. The Gleason, the T-staging, as well as the serum PSA, those are parameters that form the grouping of the low, intermediate, and high risk. Now, all of the patients were treated, about 90%, half of the patients treated with 60 gray in 20 fraction, whereas the other half treated with 62 gray in 20 fraction. All the patients underwent through either the technique of MRT or VMAT. In terms of the toxicity at completion, so what we aim to do is that we want to see the toxicity outcome of our study and compare it with the existing data, particularly the CHIEFs trial. And we can see that the preliminary results indicate at completion, the gastrointestinal system and the genitourinary system, we have 29.7 and 26.7. Well, compare it to the CHIEFs trial, they have about 38 to 49. It seems like we have a toxicity even lesser. Now, at 3 months, we have 1.8 and 5.3 to the genitourinary, whereas in the CHIEFs trials, they have 3% and 5%, which is relatively something that statistically not significant. Now, only one patient out of our group has grade 4 toxicity, and that is only one patient for the whole cohort. Currently, we have completed the number of the study. In terms of recruiting patients, we are on a follow-up, And of course, we use a two-grading system, the EORTC, RTOG grading system, and the CTCA grading system. Now, also comparing at the 12 months of the RTOG, RTOC, RTOG scoring system, we have 3.7 to the gastrointestinal and genitourinary 8.6, while compare it to the Chiefs trial, about 5 to 12. Now, these are grouped behind about radiotherapy hypofractionation. More often than not, we oncologists are a little bit concerned of giving hypofractionation. Of importance is the radiotherapy quality assurance, where this group, we have a privilege of the group to have a critical when administering high interfraction dose of radiation. And this group actually an expert across the globe, from the Americans to the Europe. We have the group members from American medical physics, clinical oncologists, and in the Europe we have our prime PI with his team, while in the east part of the Africa we have Toilette Ngoma with Solomon and his colleague. In the West Africa, we have Ade Joseph with his colleague, and in Southern Africa, myself and Riyad Berger with our colleague. Now, what we do, this group were dedicated doing a weekly meeting for the last 2 years. It's a commitment that to ensure about a better quality assurance. Now that also, during that weekly meeting, there is a global medical physics mentorship program. Also, what we in the group is linear accelerator quality assurance using a radiochromic film, dosimetric, and a film quality pro software. Also, we use a Vespa for remote radiotherapy credential, consistent of a quality check across the trial center using a Clio and a online quality assurance data. So this is one of our candidates who presented at the AAPM in 2023. Now, the challenges that we saw is lack of infrastructure for performing quality assurance, a lack of linear acceleration preventing maintenance, and of course, equipment breaking down and data harmonization. The advantage we got, or either opportunity, is that of the capacity building, assess the barrier and facilitating the willingness of hypofractionation in sub-Saharan Africa, providing solutions to resolve the barriers. Whereas what is next to do is to expand the hypofractionation in sub-Saharan Africa for prostate CA and other cancer, also advocating hypofractionation to be incorporated into the guideline, either national or sub-Saharan guidelines. Also, the groups are preparing a publication, number of publications are out, and technical resources for the sub-Saharan radiotherapy. So, in summary, ladies and gentlemen, we are able to do a feasibility study, and hypofractionation is recommended for treatment of localized prostate CA, limited evidence of safety, efficacy of hypofractionation in localized prostate CA in sub-Saharan Africa. The preliminary results clearly indicate that acute and late toxicity is comparable to that of the Western world. We have both in the Euro-American. The Hypo-Africa leveraged the team of international experts to support the trial site with radiotherapy quality assurance, which is the more concern. The answer to it is hypofractionation for localized prostate CA is feasible. This is our funders, and I have come to the end. Just let me use 1 minute that I have. So in Africa, ladies and gentlemen, we can be able to do a trial. Therefore, I will urge different teams to come toward collaboration when they are doing a trial so that we will have a heterogeneity of information that will be applicable for all. Thank you.
Good morning, everyone, and thanks for the invitation. I think Abba did almost all my talk, so it will be very easy. No, I'm just joking. We also were thinking not to use all the time and to have some Q&A session or debate at the end, so I will also try to be quite quickly. I hope that Abba showed you that hyperfractionation is feasible in Africa. You need a team, you need help, but it's possible and it's safe. So I hope I can also convince you that we can even go a step further to what we call ultra hypofractionation for prostate cancer. And we will hear later this morning also about breast cancer. So this is a little bit the outline, but again, I will be brief because some of the topics have been addressed, likely, so we have more time. We all know about the situation of prostate cancer in Africa. We all know that is for the males in most of African countries, not all of them, is number one. I've always been intrigued by the fact that it's not the case in Ethiopia, where I'm particularly involved, but still it's interesting to see that in most of the sub-Saharan Africa is number one. We also know, so we have heard what is hyperfractionation. I must say that there are a lot of debates about how do you define hyperfractionation, moderate, severe, or ultra-fractionation. So with the Hypo-Africa group, we are also trying to write a paper, a statement paper, or some discussion paper, how to define in the best way what is hypofractionation. But in general, when we give a higher fraction dose, higher than 1.8, which is quite common in the US, or 2 gray, which is more common, I think, even in South Africa, but also for sure in Europe, above that, it will always be hypofractionation. But in general, if you would tell me, is 2.1 hyperfractionation? I have a little bit difficulty with that because for me, hyperfractionation is really maybe 3 and up. But we have many data, and I will not go in the trials published because Dr. Abba mentioned that. We have enough evidence in Western countries, US and Europe trials showing in a randomized way that hyperfractionation is safe. I think you know this graph. It's from many years ago, but it is still actually actual. And we know that even though there are many machines in Africa, most of them are in North Africa or in South Africa. I think the excellent presentation by Dr. Berger, Henriette Berger, yesterday was really showing that we have a lot of machines, but most of them are in a limited number of countries. And of course, we also know that many countries don't have radiotherapy. And it's not sometimes only a problem of machines, but also a problem of personnel. We all know this, but I think this is really the background why several years ago I really, with a group of Wilngwa and others, we said we should really introduce hyperfractionation in Africa. So we published this paper in 2017 in the South African Journal of Oncology, saying that hyperfractionation offers so many advantages that we should really try to introduce this in a safe way. And I was very happy that shortly after that, and Dr. Abba mentioned that, the AUA, American Urological Association, the American Society for Clinical Oncology, the American Society for Radiotherapy and Oncology came with a statement and with a guideline that from that moment has been really used by many, many US centers, because the concerns in those years was that if you are paid as a radiation oncologist per fraction, radiation oncologists in the US didn't want to do 20 times. They wanted to do 39 because they got more money. And after these things are changing, I am aware now that many, many centers in the US really have to give the chance to treat for 20 times instead of 39. And they advised to use or 20 times 3 gray, what we also did in Hypo-Africa, but also to make it the US people a little bit more comfortable, the 28 fractions with 2.5, because that was based in a paper published, one of the pioneer papers, for me, an inspirational paper by Pat Kupelian from LA, who really introduced the 2.5, saying that that was safe. But of course, most of his colleagues really thought he would be crazy to use 2.5 instead of 1.8. So that statement was very clear. There is no reason to think of the age of the patient, the comorbidity, the micturition problems. You should use hypofractionation, either 20 or 28 fractions. The group of Willem-Gwa looked at the costs, because we were saying, okay, 20 sounds nice, but what does it mean? So they made a model on breast and on prostate. And as you can imagine, if you go from 39 fractions for prostate to 20, or from breast also from 25 to 20, or we will hear today even less, of course you reduce the costs. And it's not only reducing the cost, making for the patient easy life to come to the hospital, but also to treat more patients. Because if you have one LINAC, what happens in some countries, and you have to treat the patient 39 times, or for breast 25 or 28 times, etc., then of course with reduction of number of fractions, you can treat many more patients. So we did this, and I am not going further because Dr. Abba mentioned that. I only want to show you that we published already several papers on hypofractionation of an Hypo-Africa study, the 20 times 3 gray. Just for you to make it clear, the 3.1 gray is for the group of moderate, of intermediate prostate cancer. So that's the reason why we use 2 schemes. But as you can see, we published paper on challenges. We published a lot of, we submitted and accepted a lot of abstracts. And we are almost now really completing the 12 years data for all the patients, and we hope to present the final data at the European Society for Radiotherapy and Oncology next May, and of course the ASTRO next year. And Dr. Abba is also preparing the paper. I will skip that. So what is next? We thought, okay, we completed the study. We will need to wait for the results, of course. It seems, I think we can say that it's safe. We know that, but we still need some fine-tuning. So we thought to go further. And to go further, I based my concepts on the published study by the group of Scandinavian radiation oncologists with Mark et al., published now already 5 years ago in The Lancet. And what he compared was the 39 fractions, because at that time, when he started the study in 2005, was the standard of care. But he compared with 7 fractions of 6.1 gray, which, you know, for some of us was something like, oh my God, how are you going to do that? But the group did a wonderful study, 1,200 patients, multi-centries, using the standard of care, which is in most of European countries, 3D CRT or IMRT. It was not obliged to have IMRT. And of course, what also in most of the patients was used was the fiducial markers. You need really to have some IGRT that makes the procedure safe. No patients got androgen deprivation therapy. The reason was to keep the data more of toxicity clear. And then this was run up until 2015. And as you can expect, or what we expected, that it will be very, very advantageous to do such a study. So what they showed is the urinary toxicity, as you can imagine, at the end of treatment, as we all know from most of the hypofractionation studies, it's higher in the hypofractionation arm. But if you look after 3 months and 1 year, there is no statistically significance anymore. Interestingly, for biotoxicity, I put a question mark because even if I read the papers 10 times, I cannot find the numbers about that. But again, you can also say at the end of the treatment, you expect a higher toxicity as compared to the conventional arm. But at the end, what is important also for the patients is to look, let's say, at 3, 6 months or 1 year. Most of my patients, excuse me, would say, if you talk about these problems like nocturia or like dysuria, is just during treatment or it's forever? No, it's only the 3, 6, maybe 8 weeks. Oh, that's not a problem, I don't care if it's not like that in 1 year after the treatment. So that's the message is late toxicity is not different. Of course, you wouldn't expect any difference in outcome because we don't think that giving hypofractionation dose will really get more overall survival or disease-free survival. I mean, the dose we are giving is higher, maybe radiobiologically, but that's not really the point of the hyperfractionation studies. But of course, what you want to know is that you are not doing less good than the conventional one. So we started this one, and very briefly, again, we started initially with the 4 Hypo-Africa PIs, as mentioned, from Nigeria, South Africa, Uganda, and Tanzania, but it's much bigger now. And we are happy to have Dr. Berger from Tigerberg. We are happy to have interest from Ghana, Zambia, Zimbabwe, Ethiopia. But of course, to put together such a study in many different countries with many regulations is not very easy. And so we will take some time. But the background is, as we did also for Hypo-Africa, we don't want to show that hypofractionation is good or is better. We know from randomized trials. But what we want to know and to be sure that in an African setting with people from Africa with a different genetic profile, with the different machines, different QA, regulations, we are doing it in the safe way as in the randomized trials. So the idea is, again, to look in 4 to 6 centers, and maybe we will get more, at the toxicity, acute and late for GU and GI, at 3 and 24 months, and compared with this toxicity with the trial from Scandinavia. We are aiming at about 68 patients, if I recall correctly. That will be the minimum to show the non-inferiority, but we will, of course, keep further with that. So we will keep some discussions points like use of fiducials, technique, and these kind of things, and we can discuss all together. So my take-home messages, which are in a way similar to the ones of Dr. Abba, is of course that hyperfractionation is cost-effective, improves patient comfort. We know that patients have to travel a lot, also in Western countries, so if they have to come 7 times instead of 20 or 39, will be, of course, an advantage. If you have not a lot of resources in machines and personnel, 7 times will be really ideal in most of the cases. We have shown that it's feasible and is safe, but we also are aware that there is a need of some training, some education, some help, and that's what Hypo-Africa Consortium is doing. And this you already saw, it's a big group. We are meeting, because Dr. Abba said weekly, we're meeting on Saturday, on our free day. And still, that's committed by most of them. Really, there are 20 plus people, sometimes even more than 30, according to the topic. We are covering now not only prostate, but we are covering breast, we are going to cover cervical, and there is a lot of interaction on the protocols, on the QA, on the concerns that the countries have, because we really learned in these years that there are so many differences that we cannot say, okay, we do that in that way. No, South Africa is different than Ethiopia, is different than Ghana, so the regulations are also quite difficult and different. With this, I want to stop my presentation. We will be happy to answer all the questions you have.
Thank you.
So who first? Some critical questions. We like you to be critical.
Indeed.
Great. Great presentation. Very, very cool to see that we're moving towards ultra hypofractionation in South Africa. So you mentioned using fiducials for IGRT. For the U-Hypo-Africa trial, are you going to incorporate any MRI in addition to just contouring to make sure that you can delineate the prostate a little bit better? And then on top of that, what would your PTV expansions be for U-Hypo-Africa in comparison to Hypo-Africa?
So to first, the first question about IGRT and fiducials, that's also the first challenge we have, because it was not mandatory and not common to be used in Hypo-Africa. No countries in Africa used fiducials, still don't use fiducials. But for that study and also for ultra-hypofractionation, MR is optional, so is a device to be used, but we meant to have it as optional because we know there are centers that don't have that possibility, so we didn't want to prevent them to join, and maybe Abba can comment on that. So we did the same in ultra-hypofractionation. So MRE is advised, but not mandatory. To give you an example, even at Erasmus MC in the Netherlands, we don't use MR as a standard. And there are many discussions about that, but we don't think it's really necessary for all the patients. Some patients have really and certainly an advantage, but not all of them. And for the PTV of a hypofractionation, I think it will be, I believe it will be 3 millimeters and a 0 to the rectum, but maybe Abba can add on it.
Right. Thank you, Prof. Luca. Like just Prof. Luca mentioned that in Africa, low middle income country, MRI is not something that is commonly in the tertiary institution. You can be able to have it for your radiotherapy patient. However, if you see our inclusive criteria on the Hypo-Africa, moderate hypofractionation, either group of patients to have CT or PET PSMA scan, which we use that for the staging, as well as also to see that the localized disease. But for MRI, it's not absolute indication for our group to be inclusive. While in terms of the margin, of course, margin is always, that is part of the radiotherapy quality assurance, and preparation of this patient in terms of their bladder preparation and the bowel preparation matters. So we do very adhere to the preparation of the bowels and to see the rectal diameter. And so our margin for the hypofractionation, moderate hypofractionation, the posterior margin we use 5 millimeter, while for the ultra hypofractionation, we want to further go even lower, about 3 millimeter or so. So it's something that we have to see, and we are doing a daily con-beam CT for the patient. So it's something that is we see, and then we adopt, we learn from it, and then we just adjust our protocol, especially in terms of bowels and then bladder protocol, just to adhere to producibility. Yes, Dr. Riadberger.
Thank you, and thank you for the presentation. I just wanted to ask you to explain a little bit about the implementation of a new technique like this. I know we've talked about this. What is the structure within Hypo-Africa, and as an example to others, how are you supporting sites to adopt a new technique in terms of using different fraction sizes, especially with the QA that you mentioned? How are you approaching that? Because it can be very uncomfortable for sites to feel safe in adopting a new technique like this.
I will say something about the fiducials, and then I think you can comment better on that question. So the Hypo-Africa Consortium is meant to help the sites introducing these new techniques. So to give you an example, the challenge we have with ultra-hypofractionation is the fiducials implantation, because it's not common in Africa. So we have found a system for that. We are working already. I was working already for this for half a year, but we succeeded. So we found a company that sorted out all the regulations in the countries that will participate to get permission to get fiducials to the country, and we have that now. luckily. Sometimes it's more paperwork, sometimes it's much easier. And we have a neurologist from the UK. I think Dr. Frank is originally from Nigeria, but I'm not sure. And he will travel to the sites to instruct the local urologist to implant fiducials. In general, these fiducials will be implanted by urologists. I mean, it's possible that radiation oncologists do that, but we understand from our PIs that they don't prefer that. We are also not doing that at Erasmus. Urologists are doing that. So that's one part. But I think the most part you are mentioning, Riet, is what all the steps of the introduction of the technique, and I think Abba can tell you everything about it.
Right, like just Luca mentioned. So one of the things that the Hypo Africa does is that prior to the team joining, there is a survey that is given for every center to have a minimum to know their capacity. That do they have that capacity of participating at the trial level? Then in terms of employing new techniques, so the group of the quality assurance, we do a peer review. So you will have, for instance, before your first patient to be treated, you shared your plans. We go through the whole process and see how accurate in terms of all the guidelines in terms of the ICRU guideline. So making sure that, okay, did you follow all the tick box? And then we work alongside with the medical physicists and RTT very closely. We work entirely on daily basis. And if there are incidents or any event happen, because we are meeting weekly, they report immediately. And also, additionally, the VESPA is an online quality assurance for the machine. So we know that the calibration of your machine is within the range of the international standard. So quite a lot of an effort is being given, especially from the medical physics expert. Yeah, right. I know our time is...
I think we have to go.
Okay, thank you, ladies and gentlemen, for the opportunity.
Thank you, Dr. Malloum and Dr. Incrocci. Now, next, I would like to invite Dr. Shiao, who will be talking about prostate brachytherapy in resource-limited settings. Thank you.
Hi, everyone. Whoa, that's really loud. I'll step a little bit further back. I'm Jay. I'm a radiation oncologist at the University of Kansas, and it's a pleasure to be here and to interact with our African colleagues. And today I'll be talking about the advantages of brachytherapy for prostate cancer in resource-limited settings. No disclosures. So this is a quick outline in terms of what I'm going to be discussing today. The first topic is going to be why we even consider brachytherapy for prostate cancer. And then after that, I'm going to go over some literature for monotherapy and brachytherapy boost, and I'll end the presentation on logistical differences between HDR and LDR prostate brachy. So why brachytherapy? Brachy is a Greek word for short. The idea is to be able to deliver radiation treatment to the target with a short range, allowing adequate dose to the targets that we're trying to treat while avoiding excessive dose to normal tissue. Like other radiation techniques, with brachytherapy, the risk of incontinence is minimal. And as you can see in the figure to the right, what we're trying to achieve is dosimetry that limits dose to normal tissue organs. The top left there, you see a step and shoot IMRT plan that has some low dose radiation to surrounding structures. VMAT, you have a 360-degree approach where you may have some low dose that's to some normal structures around in all degrees that the radiation is delivered. And then in the bottom left, you have a figure of protons, where at KU we do an opposed lateral approach, and some of the femoral heads get some lower dose of radiation as well. And then with brachytherapy, it tends to be a little bit more conformal. In addition to that, with brachytherapy, we have less time to complete treatment. With LDR, it's typically just one day, one implant, the patient leaves and they go home. And now we have literature to show that for HDR, it can be as low as 2 implants that is usually delivered 1 to 2 weeks apart. And compared to external beam approaches with conventional fractionation, that might be closer to 8 weeks. Now we have 4-week options, and we also have SBRT as well. Brachytherapy tends to take a little less time to complete the treatment in comparison to the external beam approaches that are available. And overall, there's little time lost to normal activities with brachy. I'll go over this a little bit later after I've covered some literature. The NCCN is the National Comprehensive Cancer Guidelines. We use this a lot in the States for our standard of care. And they endorse brachytherapy as mono treatment for very low risk, and favorable intermediate risk. Monotherapy being that brachytherapy itself is all that's needed for curative intent for these patients. And there's also doses and implants that we can do for boost for unfavorable, intermediate risk, high risk, and very high risk. So there's a lot of literature out there for brachytherapy, so I try to focus on a few of the seminal trials that have more recently come out that have guided our practice. The first manuscript and study that I'm going to discuss is out of MD Anderson. Steve Frank published this in the Red Journal in 2018. He treated 300 patients with LDR brachytherapy monotherapy. He used different radiation sources, iodine, palladium, and cesium. And of the 300 patients that he accrued, most of them had favorable intermediate risk prostate cancer, about 65%. 35% had unfavorable intermediate risk, and he followed them for about 10 years. They had pretty excellent outcomes. There was only 10 recurrences of all the patients that were treated, and the 5-year freedom from biochemical failure and biochemical progression-free survival were pretty good, at 95 to 97%. In terms of the toxicities, so in prostate cancer, these patients usually do pretty well. So what we're trying to do is limit the toxicities, just like the previous talk. We always talk about this for our prostate cancer patients. And 85 patients had late grade 2 GU toxicity, which means requiring some sort of medications to help with the side effects that they experience. And they had very few grade 3 toxicities. So that's some sort of surgical intervention to help them with their side effects. Only 4 patients had urethral strictures, and they had 2 late grade 3 rectal toxicities. One was a proctitis that was treated with argon plasma, and one had a biopsy that led to an ulcer. So this is a figure of the outcomes. As you can see, the curves look really good. It's a single-arm phase 2 trial, and patients over the course of 8 to 10 years after treatment had a very low risk of biochemical progression. And this is the side effect profile that happens after brachytherapy. So you can see there that after the implant itself at time 0, they had a peak in their urinary side effects with an increase in their IPSS score. And then over the course of 6 to 12 months, those side effects resolve and get close to their baseline. That was the same with the sexual vitality and bowel scores as well, in addition to the urinary side effects. So what they found through this is that with brachytherapy monotherapy, we have pretty excellent outcomes with minimal toxicities long term. Then there's also RTOG0232 that was recently published in the JCO in 2023. They looked at a similar population of patients with intermediate risk prostate cancer. This was a randomized trial of 588 patients, and all of them also had intermediate risk. The majority of them had Gleason 7 prostate cancer. Some had Gleason 6 with a PSA more than 10. And the randomization here was brachytherapy alone versus combo treatment, where the patients were treated with both external beam and brachytherapy. And the idea when they ran this trial is that maybe for intermediate risk, combo treatment might outperform brachytherapy. I should say very few patients got hormone therapy. 92% did not. And what they found was that there was very little difference in outcomes, and it wasn't statistically different. So for the patients that were treated with brachy mono, they did just as well as the patients that were treated with combo therapy, looking at the freedom from progression and the Phoenix criteria to identify biochemical progression. And they did a post hoc analysis because when this trial was originally run, we didn't have the subcategorizations that we see as commonly now between favorable and unfavorable intermediate risk. But what they found was that when they looked at the cohort of patients that had grade group 2 disease and grade group 3, the outcomes were still similar. So even if you had 4+3 prostate cancer treated with brachytherapy, monotherapy, they tended to do just as well as the patients that were treated with combo, with similar outcomes in regards to biochemical progression. So with this trial, you can advocate that for brachytherapy monotherapy, it's an option for intermediate risk, and it can be an option for patients with unfavorable intermediate risk prostate cancer as well. If you were to do combo treatment, just like we see in some other trials that I'll discuss in a little bit, there's more toxicity. So with monotherapy itself, there tends to be less GU and GI toxicities in comparison to patients that were treated with combo. And that persisted through the years as well, both early and late, for both grade 2 and grade 3. So if you can avoid a combo approach for patients, that would be ideal from a toxicity standpoint. So why do we perform brachytherapy monotherapy? For the sake of time, I didn't cover any HDR literature, but in general, it's pretty, the time for completion of treatment is minimal. It's usually just 1 to 2 procedures. There's more conformal dosimetry avoiding dose to normal tissue. The cure rates are equivalent to our external beam approaches, and it's for the convenience of the patient with a number of procedures and implants that we have to do. So that's brachytherapy monotherapy. I'll move on to some literature for boost. So this is the landmark trial that many folks here are probably aware of. SNDRT came out of Canada, I believe it was in 2016, 2017. And they included patients that had high-risk prostate cancer, and they also included some that had intermediate risk. So Gleason 8 or higher, PSA greater than 20, T3A or higher disease. And they also had some intermediate risk patients, Gleason 7, PSA 10 to 20, and T2B or T2C disease. They excluded patients that had very high risk, so PSAs greater than 40. At that time, they only had CT and bone scan for staging, so unlike our modern imaging techniques with PSMA and MRI, they only had CT and bone scan, so with a PSA greater than 40, there's always concern for spread of disease at that point. They excluded patients that had T3B or higher disease, and with brachytherapy, we want to make sure that we can implant the prostate well. So there's a certain prostate volume that we have to be able to look at and be able to put the seeds or catheters in. And in SNDRT, it was all LDR. So they excluded patients that had a large prostate volume, and all patients were treated with 12 months of hormone therapy. The randomization here was external beam only, conventional fractionation to 78 gray. And then the other arm, patients were treated with external beam to the pelvis, just like in the external beam only arm, and they followed that with brachytherapy boost with iodine 125. So this trial showed that the rates of quote-unquote cure and biochemical control was higher in the patients that got brachytherapy. So you can see at about year 4, there's a split in the curves, and the biochemical benefit was achieved with a brachytherapy boost. There wasn't any difference in survival. There wasn't any difference in metastasis-free survival. But regarding the biochemical failure rate, it was lower if you were to have been treated with the brachytherapy boost. Now, a criticism of that trial is that the 5-year cumulative toxicity was much higher for patients that got brachytherapy. As you can see, the numbers are much higher. Cumulative incidence of grade 3 GU was 18% compared to 5%, which is quite high. And for GI toxicity, it was 8% compared to 3%. There's also this meta-analysis from Kishan and his colleagues out of UCLA that was published in JAMA, and they focused on Gleason 9 and 10 prostate cancer. And they found that based on their meta-analysis, patients that got brachytherapy boost had a 5-year improvement in prostate cancer-specific mortality, distant metastasis, and all-cause mortality. So for patients that had probably a higher Gleason score, you may want to think about brachytherapy as a boost as well. And then this was recently published out of Japan. It's the TRIP trial. It was in the Red Journal in this year. It was a multi-center phase 3 trimodality trial. All patients were treated with brachy, external beam radiation, and hormone therapy. 332 patients were included. All of them had high-risk prostate cancer. And the randomization here was 6 months of hormone therapy versus 30 months of hormone therapy. So quite different in terms of lengths of hormone therapy. And what they found was that in terms of outcomes, the arms did similar. Now, this was a superiority design, not a non-inferiority design. That said, if you look at the curves, they look pretty convincing, and they don't look like they separate at all. So outcomes were not statistically different when we were talking about biochemical failure, distant mets, and survival. And over time, techniques with LDR have also improved, so the amount of grade 3 toxicities that we see here were relatively minimal. 2 had urinary bleeding, 1 had urinary tract pain, and nobody had grade 3 rectal toxicities. So in summary, why do we consider brachytherapy boost? There's trials that have demonstrated a biochemical benefit. You can consider shorter durations of hormone therapy, and there's also a possible survival benefit. So this is kind of to summarize back to some of the literature that have contributed to our guidelines in terms of our recommendation. You can consider monotherapy for low risk and favorable intermediate risk cancer, and boost for unfavorable intermediate high risk prostate cancer. Now, let's talk a little bit about logistics and the difference between LDR and HDR. I'm going to skip this slide for the sake of time. We have to select our patients well for brachytherapy. So there are some absolute contraindications that are listed in our guidelines and things that would preclude you from being able to do an implant. If they have a rectal fistula, if they're unsuited for anesthesia, if there's no proof of cancer, if you can't put a transrectal ultrasound in and they don't have a rectum, then you can't perform an implant. And then on the ABS guidelines, they also list a history of ataxia telangiectasias, but I haven't seen that in any of my clinical practice. And I list these things as special considerations as well, because I would say that you may have differing thought processes across brachytherapists in terms of patients that you're willing to implant, because we do salvage radiation all the time for patients that have prior pelvic radiation. You're always a little bit more concerned about bowel toxicity for someone that has inflammatory bowel disease. And again, these scores for the prostate volume and urinary scores are important to select patients that will do well with your brachytherapy implant. So the difference between HDR and LDR. HDR is also called temporary brachy, where the iridium-192 source is delivered over the course of minutes. And for monotherapy, we do 2 implants. For boost, we only do 1. The plan optimization is essentially unlimited. When you design a radiation plan, you can tweak it however way you want based on your catheter placement. So you have lots of different ways you can optimize your plan. And you can also implant the seminal vesicles with your needles. With HDR, as you guys know, if you do GYN brachy, you step out of the room away from the afterloader, so there's no exposure to staph for radiation. And the patient day from beginning to end can go anywhere from 3 to, I would say, 8 hours. LDR is permanent. The sources are typically iodine or palladium. It's low dose rate, so the radiation is delivered over months instead of minutes. Once you drop a seed, you can't take that seed back, so the optimization is limited, and it's a little bit more difficult to implant the seminal vesicles. The radiation exposure to staph is minor, but there are some precautions that the patient has to take with radioactive seeds, and the patient day tends to be shorter for the implant. It's 2 to 3 hours. So the supplies that are needed for brachytherapy are actually not that much. You need something for imaging, so ultrasound, the probe itself, and the stepper. And then for HDR versus LDR, it's essentially needles, catheters, the template itself, and then any device that can help you insert the needles. So at KU, we use catheters. I don't use a template. I have a freehand approach. For LDR, we use the MIC applicator, the seeds itself, and the needles. And what I don't have shown here is you also need the software to be able to design a brachytherapy plan. And of course, for HDR, you need an afterloader. And of course, you need a good team, because at the end of the day, if you don't have the right people that are interested in helping you develop this program, it won't work. So these are some pictures from our team at KU when we implemented our HDR prostate program and some of the staff there. And you have to have a physicist that really focuses on safety and quality assurance. And you have to have nurses that are compassionate to care for these patients while you're working on contouring and planning. I'm going to skip this animation as well for the sake of time, but essentially for HDR, you insert the needles, capture an image, design the plan. So this is how we do it. We have a general idea of how we're going to place our catheters that we mark on the skin in the direction of where we're going to place the needles for HDR. This is kind of what the needles look like after the implant has been done. And then we create this template at the end of our procedure to secure all the needles in place. And this is a video showing our HDR implant. So we do a CT-MR-based workflow. So after the needles have been placed, we get a CT scan, we contour out the bladder, the rectum, the urethra, and those are all avoidance normal tissue structures that we're trying to constrain. And after all the needles have been placed, we're lucky enough at KU that we can also get a MRI on the same day as our CT implant. So what I'm going to show here next is that once we have the CT done, contours done, we also have a fused MRI that also helps us with our contours where we can identify the cancer itself and identify the normal tissue a little bit better. There's also ultrasound-based techniques that are a lot quicker than CT-based. You have to have the right software for that, but like an LDR implant, once the patient gets put under anesthesia and you design a radiation plan, you deliver the treatment before the patient wakes up. So that experience is a lot shorter and a little bit more convenient for our patients as well. There's also LDR. We do LDR at KU as well, and we do ultrasound-based live planning. The patient is under anesthesia for about 1.5 to 3 hours. And we use the MIC applicator. So what you're seeing here is it's sort of there's a cartridge that has seeds that get placed into the MIC applicator itself when we push out seeds one at a time through the template. And we create a radiation plan based on the ultrasound images that we get to identify the prostate. And we also do a post-implant scan to verify that the dosimetry looks good. And then just to wrap up, some recent data that have shown differences with HDR versus LDR. So there was a paper out of Fox Chase that looked at the differences in urinary scores, and you can see that at about 3 to 6 months, LDR tends to be a little bit higher, and it normalizes a year or two out. And then Memorial Sloan Kettering also published their phase 2 experience where LDR cumulatively tends to have a little bit more urinary side effects. And the most high-level evidence that we have comparing the two is Juanita Crick out of Canada. They recently published this paper comparing HDR and LDR boosts, and what they found was that HDR peaked a little bit earlier for urinary scores and recovered. LDR persisted a little bit longer. And then for GI toxicity, there was a persistent difference between HDR and LDR. And then they recently presented this at the World Congress of Brachytherapy, looking at efficacy, because we have to make sure that the patients are cured in addition to the side effects themselves, and there was no difference in overall survival and biochemical failure-free survival between HDR and LDR. So in conclusion, the advantages of brachytherapy for prostate cancer in resource-limited settings is that you really only need a few pieces of hardware to set your program up. There's limited dose required for external beam radiation. For monotherapy, you don't need external beam at all. And then for boost, you have less microscopic doses of radiation that are needed. There's less downtime, and brachytherapy boost offers improved biochemical control, and you can consider less hormone therapy for high-risk prostate cancer, and there's also a possible survival benefit. I think I went over a little bit. Sorry about that. Thanks.
Thank you, Dr. Shiao. Next, I would like to invite Dr. Kahakwa, who is a registrar at Ocean Road in Tanzania, and he'll be talking about factors associated with biochemical failure in localized prostate cancer. Thank you.
Good morning. My name is Atukuzwe Kahakwa. I'm a resident in clinical oncology at Muhimbili University of Health and Allied Science. So I'm going to present my research proposal, which I'm currently working on. Unfortunately, I don't have preliminary result yet, just a proposal, currently in my data collection. So the title of my proposal is Factors Associated with Biochemical Failure in Localized Prostate Cancer Treated with Radical Definitive 3D Conformal Radiotherapy and Androgen Deprivation Therapy at Ocean Road Cancer Institute from 2018-2021. It's a retrospective cohort study. So I'm the PI, and my supervisor is Dr. Emmanuel Ugina and co-supervisor Christina Malchel. So this will be my outline. So prostate cancer is a significant public health concern in Tanzania and globally. And in Tanzania, prostate cancer is the leading cancer among male, so accounting for more than 4,800 cases each year according to the Global Can 2020. And at Ocean Road, we annually treat more than 200 new cases, and majority of them present at a late-stage disease. So 3D conformal radiotherapy has been a standard treatment for prostate cancer. However, due to the technological advancement, IMRT and IGRT have largely replaced the 3D conformal, but unfortunately all these more conformal techniques are still not available in low and middle income countries, including Tanzania. So most of the centers in low and middle income countries are still practicing the 2D technique. So Tanzania, specifically at Ocean Road Cancer Institute, we transitioned from conventional radiotherapy using a Cobalt-60 machine to a conformal treatment with 3D conformal radiotherapy technique with a linear accelerator machine in 2018. And this transition allowed us to have for dose escalation, and we were able to give a higher dose with minimal toxicity to the organ at risk. However, the treatment outcome for patients with prostate cancer receiving 3D conformal radiotherapy in Tanzania are still not known. So our problem statement here is that prostate cancer is a significant health concern, and while 3D conformal radiotherapy is widely accepted treatment modality, a subset of patients experience treatment failure, which is characterized by biochemical recurrence, local recurrence, and distant metastasis. Despite adopting advanced technique at Ocean Road Cancer Institute, remain a gap in understanding the specific factors contributing to the treatment failure among patients undergoing the 3D conformal technique. So the aim of this study is to analyze factors associated with the biochemical failure in patients treated with external beam radiotherapy using 3D conformal technique and androgen deprivation therapy. So by identifying this factor, we aim to address the critical gap regarding treatment outcome at Ocean Road Cancer, thus providing the insight into the specific treatment failure. So the rationale of the study is to understand the factor contributing to biochemical treatment failure in patients receiving 3D conformal radiotherapy. This knowledge can significantly influence the clinical decision-making, patient counseling, and develop targeted intervention and enhance efficacy and reduce biochemical failures. So we hypothesize that certain clinical pathological characteristics such as Gleason score, tumor stage, pretreatment PSA, and patient demographic characteristics such as age and comorbidities, as well as treatment-related factors such as radiation dose, treatment duration, and ADTA duration are associated with increased risks of biochemical failure in localized prostate cancer, a patient treated with 3D conformal plus ADT at Ocean Road. So our primary research question here will be, what are the factors associated with biochemical failure in prostate cancer patients treated with 3D conformal plus ADT for curative intent at Ocean Road from 2018 to 2021? We have three secondary questions. The first one is, what are the percentage of biochemical treatment failure? Second one, what is the predictors of biochemical treatment failure? And the third is, what are the association between biochemical treatment failure and the survival of the patient with localized prostate cancer treated 3D conformal at Ocean Road from 2018 to 2021? So the broad objective aim to determine the association between biochemical failure and the treatment failure in prostate cancer patients treated with the definitive 3D conformal for curative intent at Ocean Road, but also the influence of biochemical failure to the survival outcome. So the specific objective also is to determine the clinical pathological and social demographic characteristics of localized prostate cancer treated for definitive radiotherapy, also to determine the dosimetric characteristics, also to determine the prevalence of biochemical failure and the association between biochemical treatment failure on 3-year overall survival. So this is our conceptual framework. It's built on a set of independent variables which collectively impact the dependent variable. So that here the dependent variable will be the biochemical failure. This is our primary dependent variable, primary outcome, biochemical failure, which is defined according to the Phonex definition of biochemical recurrence, which identifies a PSA rise more than 2 nanogram per mil from the nadir PSA. This is the lowest PSA attained after external beam radiotherapy. So the social demographic characteristics such as age and pre-existing patient conditions or comorbidities may, together with the clinical pathological characteristics such as the grade of the tumor, Gleason score, and the baseline PSA, may influence treatment-related factor affecting biochemical failure, also affecting the biochemical-free survival, metastatic survival, and overall survival. So the methodology, this is the retrospective cohort study design. Study site will be at Ocean Road Cancer Institute. The study population will include all histological proven prostate adenocarcinoma with localized disease who are treated with 3D conformal radiotherapy plus ADT. So the inclusion criteria will be all male patient with adenocarcinoma, proven positive, with the localized disease. We will exclude all patients with missing histological data and also follow-up notes, or with distance metastasis. So the study duration, we will include all patients treated since January 2018 to December 2021. Sample size estimated to be 277. So our primary outcome is biochemical failure, and the secondary outcome will include overall survival, biochemical free survival, and metastatic free survival. So here the key factors which we're going to investigate will be demographic characteristics, clinical, and also treatment-related factors such as the use of neoadjuvant ADT, use of ADT duration, and chemotherapy. We also focus on the dosimetric parameters. So the analysis will be performed using SPSS version 27. So both a univariate and multivariate analysis will be used to determine the association between associated factor for biochemical failure. So we will compare those with biochemical failure with those without biochemical failure using binary logistic regression in a univariate analysis. And those with a factor less than 0.25 will be taken for multivariate logistic regression. And those in multivariate logistic regression, those with a p-value of less than 0.5 will be considered statistically significant. Also, survival curve will be drawn by using Kaplan-Meier methods, and we will compare using the log rank test and Koch regression analysis to determine the overall survival, biochemical failure, free survival, and metastatic survival. So data collection will be done using the structured questionnaires. This is through retrospective extraction of patient information from medical files, and both hard copies and soft copies. The dosimetric parameters will be obtained from a computer with special software. This is the TPS, the treatment planning system. So we anticipate a lot of limitation based on the nature of the study. It's a retrospective study, so a lot of missing data. So a possible solution for the missing data will be omitting a variable with many missing data. So variable with more than 10% missing data will be omitted during analysis. And for variable less than 10%, we'll use multiple imputation method to fill the missing data. Thank you very much.
We do have 3 minutes. If there are any questions for Dr. Kahakwa, they are welcome.
Thank you. I think it's very interesting. I have two questions. One is, do you expect differences in results as compared to what we know from published studies in, let's say, Western countries, specifically for you? In Tanzania. And the second point is, I will encourage you to look at waiting time, so the time the patient comes to you and when radiotherapy starts, when the treatment is done according to the overall treatment time that has been advised, because if you take 3 months because the machine is down, that can impact your results.
Yeah, thank you very much. Thank you very much. I'll start with the second. The advice, I really take the advice, and I'm already looking into that. And for the first question, yes, I do expect we could have different results based on the type of patient we see. Yeah, so, yeah, we can have different results. Yeah.
Also, we have to characterize our patients as well. So we don't know these factors, especially in our setting. We have studies based from outside, but we don't know exactly what is happening in our
All right, thank you, Dr. Kahakwa. And as a reminder, if there are any questions for any of our other speakers, please feel free to find them during the breaks. So let's keep on moving. Next, I would like to invite Dr. Parag Sanghvi, on the stage, please, and he'll be talking about modern indication and doses for heme malignancies. How low can we go? Thank you.
Good morning, everybody. It's a pleasure to be here, and I want to thank GHOS and Radiating Hope for inviting me here. We're going to change gears a bit. We've been talking about dose escalation, hypofractionation, and we're going to switch to talking about how low can you go in lymphoma. This is the world I live in. It's the other end from head and neck cancer, and it's a really exciting world to be in. I have no disclosures. So today I'm going to talk about really Hodgkin lymphoma, diffuse large B-cell lymphoma, and low-grade lymphomas. And if we have time, we'll talk about myeloma. But if we don't, the slides are here for you to take home. So if you look at the history of lymphoma over the last 60 years, this is truly a remarkable disease where you can see that our radiotherapeutic fields have come down drastically. We've gone from an era of total nodal radiation, subtotal nodal radiation, and radiation doses of 30 to 45 gray for Hodgkin lymphoma, now down to doing involved site radiotherapy, involved node radiotherapy, and really down to radiation doses of 20 to 30 gray. And I put this slide because I always feel like I have to remind my medical oncology colleagues because when they think of radiation for heme malignancies, they still think of fields from 1960s and 1970s and don't really realize what we do in the modern era. So as we talk about Hodgkin lymphoma, really two main considerations to think about. The most important thing in Hodgkin's really is risk stratification, because we make all of our decisions, whether it's about the number of cycles of chemotherapy and the dose of radiation, as based on how we stratify these patients in terms of their risk. And then the second question, particularly I would say in the US, is the consequences of omitting radiotherapy. This can be a big issue because this is often not available. I just wanted to put a summary slide here. So this is just looking at early-stage Hodgkin lymphoma patients as to who is eligible for de-escalations, both in terms of chemotherapy and radiotherapy, and then who really needs 4 cycles of ABVD and 30 gray in the modern era. Let's talk about a couple of trials. So there are 3 large trials now in the PET era. And all of these trials have really looked at both the prognostic and predictive value of PET-CT to ask the question, can we eliminate radiation in early-stage Hodgkin lymphoma? And the bar is high. So if you think about German Hodgkin's HD10 trial, which is the pre-PET era trial, this is patients with very favorable disease who got 2 cycles of ABVD and 20 gray of involved field radiotherapy. When you look at their 5 and 10-year cure rates, again in an era before PET-CTs, 95%. So that's the bar. So this HD16 trial is a German trial that looked at exactly the same cohort of patients, very favorable patients with Hodgkin lymphoma, gave them 2 cycles of ABVD, and then looked at metabolic CRs. So if your PET-CT after 2 cycles showed a Deauville score of 1 or 2, then you were a candidate to be de-escalated, and with that de-escalation meant no radiotherapy. You just got 2 cycles of chemotherapy. And then for patients who had Deauville scores of 3 or 4, regardless of whether you were on the standard arm or the experimental arm, you got the 20 gray radiation. So how did we do? This is the 5-year results now published, and you can see that when you look at patients getting radiotherapy, the 5-year cure rates are 93%. And when you get just chemotherapy alone, those cure rates are about 87%. So you can see about a 7% difference in cure rates for these patients. And then what about patients where your Deauville score is a 4? So again, the other question that this trial really answers is that prognostic value of a PET-CT after 2 cycles. And what you see here is patients who get 2 cycles of ABVD and have a Deauville score don't do very well, whether you give them radiotherapy or not. And you can see that here now you can see the difference in disease-free survival or local control is on the order of 20%. So what this tells us is that if you have a Deauville score of 4 after 2 cycles of chemotherapy, you really need more chemotherapy, irrespective of what your biologic risk was based on your anatomic sites of disease or volume of disease. This is the EORTC trial, also building on the same concept of can you eliminate radiation? This trial had 2 arms, a favorable arm and an unfavorable arm. In the favorable arm, the question was, can you give 3 cycles of chemotherapy with radiation, or can you eliminate radiation and just give these patients 4 cycles of chemotherapy? And then the unfavorable arm, the question was, can you do the standard, which had been 4 cycles of chemotherapy and radiation, or can you eliminate radiation in a cohort of patients and give them more chemotherapy? So now 6 cycles of ABVD in these patients. In this trial, there was a preset interim analysis set to see how this trial was performing. And at that preset interim analysis, the trial actually did not meet its non-inferiority criteria. So for the favorable patients, if you look at their 1-year progression-free survival, patients who got radiotherapy did very well, 100% control rates. But patients who didn't get radiotherapy after chemotherapy, so even though they got an extra cycle of chemotherapy, their 1-year progression-free survival was 95%. Similarly, in the unfavorable patients, similar outcomes, where patients who got 4 cycles of ABVD and radiation did better versus patients who got 6 cycles of ABVD did worse. So this actually led to an interim amendment in the trial where now everybody got radiotherapy. So they actually called patients within the last year if they had gotten just, if they had been randomized to just chemotherapy alone arms and actually gave them radiotherapy. And all patients subsequently in the trial got radiotherapy irrespective of their PET response after 2 cycles of chemotherapy. And here are the results. So now looking at 5-year results. So this is again looking at favorable patients. And what you can see here for the 5-year results, that difference is substantial. Now you're looking at a difference of about 12-13% in favorable patients who didn't get radiotherapy after chemotherapy, even with a Doble score of 1 or 2. Similarly, in the unfavorable arm, that margin of difference is small, but what I want you to be mindful of, these patients got 6 cycles of chemotherapy. And there are consequences to 6 cycles of chemotherapy, as I'll show you in a second. And at 10 years, so now you can look at, again, that difference becomes even more dramatic. Now you're approaching a difference of almost 15% in favorable patients. And remember what I said earlier, the bar is 95% cure rates for these patients. So, going down to 85% is a substantial loss of cure. I think the other thing that we have to be mindful in Hodgkin lymphoma is what happens when you relapse. Relapses are not easy to salvage in Hodgkin's. It doesn't just mean that you get more chemotherapy. The standard of care, even today in 2024, is that you have to then consolidate with an autologous stem cell transplant. And even with those types of intensive therapies, if you look at patients with relapsed Hodgkin lymphoma, their 5- and 10-year overall survival is still on the order of 40 to 60%. So you've taken somebody who could be cured with consolidation radiation, and for a group of patients, you've really rendered them incurable. In terms of radiation dosimetry, so I would say that I'm a firm believer that no matter where you are in the world, you can safely treat Hodgkin lymphoma, and these are the parameters that we think of in the modern era. So with involved site radiotherapy, with involved node radiotherapy, you're really looking to keep that mean hard dose anywhere between 5 to 15 gray. You want to spare breast tissue as much as possible, which is really very, very possible in the modern era because majority of patients don't have axillary nodal disease. And then here are some of the lung and thyroid parameters that we try to accomplish. The biggest thing I find, no matter where you're in the world, especially with these modern machines like Halcyon and Ethos that many are getting here now in Africa, that you can do deep inspiration breath hold. And so if you're thinking of treating Hodgkin's patients, the biggest bang that you get really is by using deep inspiration breath hold in these patients. And here's just showing you how you can spare the heart. This is just showing if you even do an APPA field to treat these patients, you can spare the heart substantially in vast majority of Hodgkin lymphoma patients. Similarly, deep inspiration breath hold also allows you to spare the lungs because you increase that tidal volume and you're going to spare more of the lung parenchyma for these patients. Again, just showing you what deep inspiration breath hold looks like. And I'm going to walk through one of my patients. This is actually a 43-year-old physician that now I treated about 10 years ago who had very bulky Hodgkin lymphoma. You can see involving the neck, involving the mediastinum, involving our left axilla, and involving our internal mammary nodes. She got four cycles of chemotherapy, and I wanted to just show you her disease. So this is the pre-chemotherapy disease on her PET CT. And then after 4 cycles, she came in and had multiple opinions about what to do, whether to give her 2 additional cycles of chemotherapy because of her bulk, or to give her radiotherapy. And we ultimately settled on radiotherapy for her as consolidation. You can see that she had a very robust response, so a Doble 3 after 2 cycles of chemotherapy, and a Doble 1 after the 4th cycle of chemotherapy. So how do you treat her? So this is before I had access to protons. So I treated her with photons. and then really talking about the techniques of radiation for her. So the concept of involved site radiotherapy is you only treat the disease that existed. So you typically contour your pre-chemotherapy disease, and then you adapt it to your post-chemotherapy CT. And the margins we give really in terms of a CTV margin, you can see are extremely, extremely tight. On the order of 0.5 to 1.5 centimeters. And generally, I'll tell you that anywhere near the heart, the margins are anisotropic. If the pericardium is not involved, you really don't need to give that CTV margin going into the heart. And then PTV margins, depending on your technique and depending on your image guidance, anywhere from 3 millimeters to 5 millimeters. Just showing you some contouring. So here you can see her disease, her pre-chemotherapy disease, her post-chemotherapy CTV, and then you can see that very tight margin. I did give more margin, up in the neck, about 1.5 centimeters, but then you can see, inferiorly toward the heart, that margin is really on the order of 5 millimeters. And then here's just showing you some benefits of using deep inspiration breath hold in these patients. You can see that you can really spare the heart very nicely. This is a free breathing scan versus deep inspiration breath hold with those same contours. And the heart is really out of almost out of the radiation field in this patient with deep inspiration breath hold. This is showing you just using inverse planning what those DVHs look like. You can see that with deep inspiration breath hold, you're going to spare almost everything better. Your lung DVHs improve significantly. Your mean lung dose improves. And then really where you get the biggest bang for your buck is really your mean heart dose here. So you can see that with deep inspiration breath hold, her mean heart dose is 4.5 gray, versus with the free breathing, it would be on the order of about 12 gray. This is showing you just deep inspiration breath hold looking at inverse planning versus 3D conformal. And you can see that while there are gains with inverse planning, the gains really are with deep inspiration breath hold. You can see that even here with mean heart dose, doing APPA is going to be lower than using a free breathing CT in this patient to treat her. So you can see what those outcomes are. Today, in 2024, I have access to protons, so I just wanted to kind of put this slide in to show you what the average proton patient looks like. So this is another one of my patients more recently. Again, she's 30, again, 3 cycles of ABVD followed by 30 gray of radiation. And really the big gains you see even in somebody, and she had a bit of pericardial disease here, so you can see that, even this is where protons really shine, where you can get really low mean heart doses on the order of 3 gray or less, and then really substantial sparing of breast tissue here. This is another young patient that I just finished treating, 21-year-old with really unfavorable Hodgkin lymphoma, got 4 cycles of ABVD and 30 gray of radiation with protons. And you can see again, mean heart dose of 1.4 gray. And you can see the lung DVH, again, very, very, very nicely spared. We now typically control all cardiac substructures and really track these doses and monitor these patients lifelong for long-term cardiac toxicity. Next, I'm going to switch to diffuse large B-cell lymphoma, and I will say that particularly in the last 7 years, the trend in diffuse large B-cell lymphoma is to completely eliminate consolidation radiation. And so I love showing this picture. Don't throw out the baby here with the bathwater. You really have to be mindful of which patients that you can safely eliminate radiation in diffuse large B-cell lymphoma and which patients you should not eliminate. So there are 3 trials that have really, in the PET era, that have looked at eliminating radiation. Only one of this is randomized, which is the French trial, the LISA trial, where patients with really early stage, very favorable diffuse large B-cell lymphoma, so no bulky disease, no extranodal disease, and generally very, very healthy patients. In that trial, patients got 4 to 6 cycles of R-CHOP, depending on their IPI score, and the question was radiation, no radiation, based on metabolic CR. And in this trial, there was no difference in patients whether they got radiation or no radiation in terms of long-term disease control. But people love to extrapolate these trials where very favorable patients that younger than 60, that are super healthy, that are getting 6 cycles of chemotherapy with R-CHOP, and really extrapolate to patients that don't meet these criteria. And so I would say even in 2024, the vast majority of diffuse large B-cell lymphoma patients I see are old. They're in their 60s to 80s or 90s. Most of these patients can't handle 6 cycles of R-CHOP. They're often getting 3 cycles of R-CHOP or even mini R-CHOP. They tend to have bulky disease, they tend to have extranodal disease, and anybody who has biologically unfavorable disease, if you're doing molecular profiling, there's still a really big value for radiation in these patients in giving consolidation radiation. And there are multiple trials here to support you, in using that consolidation radiation, whether you look at Unfolder, whether you look at Recover, or even the phase 2 SWOG trial. What about radiation doses in diffuse large B-cell lymphoma? We have this classic UK trial looking at high-grade and low-grade lymphomas. What we know from this trial is that 30 gray is just as good as 45 gray in the setting of a CR to chemotherapy. So really establishing 30 gray as the dose for consolidation radiation in these patients. One of the questions that often comes up is, can we go even lower? Can we go below 30 gray? And there's really interesting data, now actually quite mature data from a Duke trial. This is a single-arm phase 2 trial where Dr. Kelsey gave virtually every diffuse large B-cell lymphoma consolidation radiation, regardless of stage. So even stage 3 and 4 patients were included in this trial. So as long as you had a metabolic CR, patients got radiation. If you had stage 1 or stage 2 disease, you got radiation to all involved sites. If you had stage 3 or 4 disease, radiation was really tailored to sites of bulky disease, because we all know that bulky disease is the #1 place where patients relapse, even after a complete response to chemotherapy. But the dose of radiation you can see in this trial was 20 gray for most patients, and then now we have 5-year outcomes, and you can see that 5-year freedom from in terms of local failures is really good. It's 98%. So patients do not fail in irradiated fields. That's the message I want you to take, even with radiation doses as low as 20 gray. You can see progression-free survival slightly inferior, so you still have a risk of relapse outside of the radiation field, but really, really good data for these patients. What are the doses to use in the modern era? I will say that I still prefer 3 cycles of R-CHOP, particularly in my older, frail patients, and consolidate those patients with 30 gray radiation if they have a metabolic CR. So anything from Doble 1 to Doble 3, I give 30 gray for these patients. In patients that are getting 6 cycles of R-CHOP but have either biologically unfavorable disease or really bulky disease, I still like consolidating these patients, particularly to sites of bulky disease. And I'll go to radiation doses as low as 20 gray, especially when they've seen a lot of chemotherapy, particularly in the abdomen, because we all know that there is a difference in GI toxicity between 20 and 30 gray, especially when you're treating large volumes in the abdomen. How about partial responses? I think this is where radiation really shines, and you should always advocate for radiation, particularly in settings where salvage therapies are not readily available. In these patients, typically I'll treat the initial volume to about 20 to 30 gray, and then just boost the area that's still metabolically active to anywhere from 36 to 45 gray. In the US, I see a lot of just locally advanced diffuse large B-cell lymphoma patients that never really come to radiation unless they need palliation. Now we have cellular therapies available like CAR T. So oftentimes patients come in for just bridging therapies or palliation. And really here I'll say it's dealer's choice. Whatever dose you can get in, however time you may have, you can give that dose of radiation. Radiation is such an effective modality both for palliation and for bridging for these patients. Just wanted to show you a couple of cases. This is one of my patients with stage 1 diffuse large B-cell lymphoma of the Waldeyr's ring. You can see, a partial response after chemotherapy, and for this patient, I did 45 gray and 25 fractions. But this is what I really see more commonly, and this perhaps I think maybe we all see commonly now, is just patients with just very rapidly progressive disease that's not responding to chemotherapy. This is a patient that I just finished treating. She was going to go to CAR T, gave 20 gray and 5 fractions right before going to chemotherapy. I'm going to end by talking about low-grade lymphomas. This is really where the success of radiotherapy comes in. Radiation doses have dropped from 40 to 50 gray, from the 60s to 90s, to really in the modern era, I live in the radiation world of 4 to 24 gray. I'm going to talk about just marginal zone lymphomas and follicular lymphomas primarily here. So for follicular lymphoma, one of the, I think, more exciting things more recently is recognizing that even patients with grade 3A disease really can be treated with radiation alone. You can eliminate chemotherapy in grade 3A disease. So really only patients that have grade 3B disease where you should treat them like diffuse large B-cell lymphoma, but otherwise 3A really behaves like grade 1 or grade 2 follicular lymphoma. In terms of radiation doses, this is the large ILROC series, just published now about 5 years ago, showing that doses of 24 gray are adequate. You can see that local control is excellent, over 90% in these patients. And this is showing you that stage 1 patients particularly can be cured with this disease, with radiation. We don't think of follicular lymphoma as a disease that we typically cure, but really stage 1 low-grade follicular lymphoma can be really cured in patients with radiation because they just don't fail as commonly outside of their initial sites of disease. This is looking at PET CTs. So if you give these patients radiation and they have a metabolic CR, they do even better. So you can see that patients really have a much, very good outcomes. Over 75% of patients, 5-year, long-term disease control overall in the body. We all know the FORT trial. This is 4 gray versus 24 gray. You can see that complete responses are on the order of about 50% with 4 gray versus with 24 gray on the order of 60 to 70%. And overall responses you can see are even much higher. So how do I select dose? For follicular lymphoma, I'll tell you that if they have early stage disease, I start with 24 gray for most sites. But I will tailor it down to 2 gray times 2, particularly in sites like the orbit, salivary glands, if they have underlying comorbidities like Sjogren's syndrome, and really older patients. Patients in their 80s and 90s, 2 gray times 2 is so rewarding. There's almost no side effects, and you can do very, very well. Again, just showing you a patient. This is a patient, a younger patient, getting 24 gray and 12 for neck disease. And this is an older patient getting 4 gray and 2, which had some perineal disease and an inguinal node, and you can see just very focal radiation for these patients. I'll end by talking about marginal zone lymphomas. Gastric lymphomas are something that we think about. Who do we treat today with upfront radiation? Obviously, anybody who's H. pylori negative. And then the other caveat, if you have molecular profiling, if your patients have this T11-18 translocation, these patients don't really respond to antibiotic therapy, and so these are patients that we typically will treat with radiation. Doses, even for gastric malt lymphomas, we've gone from 30 to 20 to 24 gray. This is a really nice series from MD Anderson supporting that. And then again, showing you deep inspiration breath hold. I wanted to just show you how nice DIBH looks, even in gastric lymphomas. You can completely spare the heart in these patients. And finally, this is the 24 gray to 4 gray. This is, again, MD Anderson data looking at patients with orbital malt lymphomas or orbital follicular lymphomas, really showing you that when you give radiation doses of 4 gray, you do have to watch these patients, but you can get excellent local control on the order of 91%. And really, vast majority of patients don't need any more than 4 gray with longitudinal follow-up. Thank you very much.
Thank you so much, Dr. Sanghvi, for the great talk. Now we can enjoy a short coffee break. We will have around 20 minutes time, and we will see you at 11:20. Thank you.